In this summary of organ support in intensive care, we're going to talk about sedation in ITU. So in this talk, we're going to cover the aims of sedation in intensive care. Now, that might seem like a silly statement at first, but focusing on what is important for sedation is crucial, and I'll explain that in a bit. Then we'll discuss your sedation options. We'll discuss the side effects of each individual sedative agent, and then finally we'll talk about how we monitor these in intensive care. So firstly, let's talk about the aims of sedation in the critically unwell patient. Sedation in the ITU is very different from an anaesthetic. The amount of sedation that a patient should receive should be proportional to the intervention or the discomfort that they may be experiencing. Then what you want to do is use the least amount of sedation so that that patient can tolerate the intervention that they are receiving. Now at baseline, that may just be an endotracheal tube which is very stimulating in your larynx, and they may need some background sedation to tolerate that. But you may be taking a patient to scan, or they may be having an intervention such as a central line. So in those times you need to increase the sedation, but each time it should be matched to what is happening to the patient at that time. And why is that important? Well, that's because there are harms to sedation. Sedation is not just this simple off switch for a patient. There are harms to using sedation, and there's also harms to over-sedating a patient. Those harms can be quite simple. That could be cardiovascular instability if you're using an excessive amount of sedation, which may cause short-term problems. However, if a patient is really deeply sedated, then they may not take over their breathing from the ventilator. And at that point, they're more at risk of muscle mass loss, which will increase the length of time that they're on a ventilator. But it goes even deeper with the brain. An over-sedated brain for a prolonged period of time increases your risk of cognitive decline in the long term. Now that is because your brain is unable to do the normal physiological processes that it does. Understandably, patients are more at risk of delirium then, if they are deeply sedated. And the one that you may not have realised is deeper sedation is more of a risk of PTSD than someone who is less sedated and can recall some of the events during ITU, probably converse to what you were thinking before. But the list goes on. These are just a brief overview of the harms of oversedation. So obviously knowing how much sedation to give is very important for your patients. But I'm going to come on to that later on how we can assess how we are doing. But first, let's go even more into the basics of the sedation options that we have in intensive care. First of all, propofol. I'm sure we've all heard of it, most commonly used in the intensive care unit. So propofol works on the GABAergic system in order to produce sedation. It's normally given at a rate of up to 30 mL per hour, and you can adjust depending on your patient response. Propofol is really useful to us because if you're on a continual sedation and then you need a quick top up, you can give a bolus and you'll have a relatively quick response to that, say if a patient becomes suddenly agitated. You can also use it in hepatic and renal failure, so it's a nice predictable drug. There's also this benefit that it reduces airway reflexes, which can help us with our airway interventions. Now, the effects that this has systemically are reduced heart contractility, which can be a problem in the septic patient, so using too much therefore can cause some harm. It can also cause relaxation of your arteries, dropping your blood pressure. And also importantly, in the long run, it's got a calorie value to propofol, and it's 1 calorie per mil. And that's just important for the long-term nutritional support of the patient. Now, there is another important side effect of propofol that is very rare, and I do want to stress this is a rare complication, and that is PRIS, or propofol related infusion syndrome. PRIS is a duration and dose dependent side effect. That is, the longer someone is on propofol, and if they're on a higher dose for a longer period of time, they're more at risk of having this syndrome. Above 4 mils per kilogram per 24 hours is when risks occur for PRIS. Now, most of our patients won't be affected by that because we limit our propofol from 0 to 30 mils per hour. Now, this is more common in the paediatric population, but it does occur in the adult population. What happens is, as there's too much propofol given to a patient, there is disruption of the oxidative phosphorylation process, which then causes cellular death. Now, this is more common in high energy tissues such as muscle, so you get rhabdomyolysis quite early. You'll see cardiac dysfunctions in terms of bradycardias and arrhythmias, and there'll be metabolic disturbances. And then subsequently, if it's not spotted or treated, it can lead to a cardiac arrest. Now, this is why we use propofol safely, and this is a very rare syndrome that we very infrequently see. Next of our sedation options is to use opiates. Opiates work on the opiate receptors and mainly the mu receptor. Depending on what opiate your unit uses, quite commonly it will be alfentanil, and a typical range will be 0 to 4 mils per hour. And there are loads of benefits to us using opiates as part of our sedation. Firstly, it's very good at numbing the airway to the endotracheal tube, so this is good for tube tolerance, and it will reduce the amount of propofol that you need. It also works synergistically with propofol because it works on a different receptor, so it can again minimize the amount of propofol that you'll require. It's also very good at pain. Now, quite commonly our patients will have a painful source such as the post-surgical patient, so this helps to address that at the same time and again reduces the overall sedation that you would need. It's also very useful for desensitizing the patient to carbon dioxide, and as such helps us gain control when we need to with the ventilator. So our examples are alfentanil or remifentanil, some units will use, and the sort of effects you get systemically is, again, it reduces the respiratory drive. Now that could be useful if the patient needs a controlled form of ventilation beyond the scope of this talk. However, that could also not be useful if we're in the weaning phase of a patient, where it may prevent them from progressing with weaning. It can also reduce your heart rate, and you may see this particularly at the early stages. If someone's very high dose alfentanil and naive, they may have a low heart rate with an opiate. So the typical ICU patient. Bringing this up now before we talk about the other sedation options, because actually for most patients these will be the two sedation options that you'll use. And this is the typical regime of sedation for a patient. On a nice calm day with nothing too much going on, nothing too stimulating, a patient will have propofol and alfentanil, somewhere between 20 mils an hour propofol and 2 mils of alfentanil. That's what it will look like at the end of the bed. And over time you can reduce this for your sedation need so that you don't give too much. But let's talk about the other agents that we have for your sedation in intensive care. Now, there's specific circumstances that you may need these, and that may be that these two were not enough. So next, let's talk about the central alpha-2 agonists. Now, when we talk about alpha, we are talking about the adrenergic system. Now, that seems weird that we're talking about an agonist, but just remember that the alpha-2 receptor is a presynaptic receptor. its job is to down-regulate the system. So by giving this, we're actually down-regulating the central adrenergic system. The examples of these drugs are clonidine or dexmedetomidine. The effect that this has is it reduces arousal. It's also good for treating pain. It has some effects on nausea, but it will also obviously reduce your heart rate and also reduce your blood pressure. So patient selection is very important for the alpha-2 agonists, and that shocked patient at that stage of the critical illness, it may not be appropriate for. So the main cons are just that. They may be limited by cardiovascular instability. Conversely, if the patient is struggling with high heart rates and hypertension in that setting, this offers a benefit. Now, importantly, overall in our trials, comparing this to just propofol alone, there is actually limited evidence to show benefit. But there are certain circumstances that they are useful. Because it causes more of a calmness in the patient, it can be useful in that agitated patient when you're trying to get them off propofol and get them off a ventilator. So you may see it being used on your unit. Next, the big one, the midazolam or the benzodiazepines on the intensive care unit. So this also works on the GABAergic system, and we use it when other options have failed, or it can be useful in uncontrolled seizures. It can be used if we need deep sedation, and it also can be used for the shocked patient where we think propofol and its effect on the blood pressure would have a negative effect on our patient, and that's more when we're in extremis with a patient that you might see it. So the cons. Benzodiazepines have the biggest delirium risk. It also has an unpredictable half-life in our patients, and that's very challenging for us because we don't know when the effects will have worn off. So this confounds the clinical picture. So when a patient is over their critical illness and we try to wake them up and they don't wake up, we then aren't able to know if this is effect of midazolam because we don't exactly know when it's worn off, or if something has happened, such as a bleed on the brain. So overall, it's not a fantastic option as a sedation option, and in most units, we would expect very senior input before starting midazolam. So those are our options with sedation. And now we talked earlier on about the harms of sedating a patient. So the big question is, how do I know when enough is enough? So let's talk about monitoring sedation in the intensive care. Unfortunately, there is nothing better than clinically assessing your own patient for response. So this isn't too challenging. To do this, you'll hear about the Richmond Agitation Sedation Scale, or RAS score. This RAS score is a very simple end-of-bed test to see how we're getting on. Now this ranges from the plus numbers, where you have your very agitated patient who is at harm to themselves or to the staff. On the other end of the minus scale, you've got a patient who is unrousable with no response to physical stimulation. And then this is where you start entering the spectrum of a general anaesthetic as opposed to sedation. So then how do we set our targets? Well, a RAS score of -2 to 0 should be the standard aim for a patient who is not going through a big intervention. The evidence shows with this, we have less PTSD and we have less delirium in our patients. It will also reduce your blood pressure support. And then, because we're reducing the muscle wastage, it will also improve patients' ventilatory weaning and them taking part in their own care. So this is really important. But there are times when we need to do RAS of -5, and that is for invasive procedures. Now obviously if we're intubating a patient, we give a big enough dose that they won't recall the intubation. But if a patient is having paralysis as part of their therapies, we also need to be aiming for that RAS -5 so that they're not aware when they try to move. Now, this brings up a really important point with procedures. Your patient is not anaesthetised. Now, most people will enter the intensive care unit and get this wrong. For that reason, when you're doing a painful procedure such as central lines, I always advocate that you would use local anaesthetic. This is preferred to you just going up on sedation whilst you do a procedure, so it's a good sedation sparing option. It also means that when you're approaching a patient, don't always presume that that patient is deeply sedated. In fact, I make a very common habit of just talking to a patient of everything I do, even if I think they're quite sedated, particularly if you're going to perform an examination. It can be very frustrating for a patient on the unit if they are aware of what's going on and someone just starts examining them. So just talk through, make them aware, and this will be a much preferred option. Finally, just a more advanced topic to bring it up, I want to talk about alternative monitoring, and that's when we can't use the RAS scale. So typically I'm talking about a patient who is having paralysis treatment. What we can do in that setting, when we've used the neuromuscular blockade, such as advanced respiratory failure, we can use a depth of anaesthetic monitoring. This might be called a BIS machine. There's different brands, so that's just one of them. And it is a very crude form of an EEG. What it does is it looks at the waveforms at the front of the brain and it estimates the depth of anaesthesia. The numbers range from 0 to 100, but 40 to 60 is anaesthetised, so that would be important in the paralysed patient. The downsides of this is it's used in theatres for anaesthetics, but long term in ITU there's a lot of questions that are unanswered and essentially it remains unvalidated. But it can be a useful tool to guide where you are with your sedation. So let's put it all together. In summary, with sedation, and to be honest, like all intensive care therapies, less is more. You want to tightly control the amount of sedation you're giving to the patient need at that time. There is a very real harm to excessive sedation in our patient, and that's why we need to be setting targets early to reduce sedation. And we can do that by using the RAS scale. The RAS scale, 0 to -2, would be very appropriate if there's no interventions that day. However, RAS -5 needs to be reserved for the patient in specific scenarios where we couldn't use that target. Thank you very much for listening to this talk on sedation. I hope that clears a lot of that up.